Susan, just checking audio and video.
Audio sounds good. Video looks good.
Great, thanks. Looks like we have everyone. I'll call to order the Green Mountain Care Board's hearing of May 8th, 2024. Two brief agenda items today, relatively brief. We have an update on the affordability standards that Mike Barber has been working on with our team. And then we have a revised budget staff presentation from About One Care from our staff. Michelle Sawyer will lead that. I'll turn to Susan Barrett for Executive Director's report.
Thank you, Mr. Chair. I wanted to alert folks to keep an eye on our monthly calendar. The month of May is turning out to be a very, very busy month for the Green Mountain Care Board. So we've added recently some additional presentations, and just to highlight, next week, May 15th, the board will be hearing a panel discussion from Vermont's providers on Vermont's global budget design and the AHEAD model. In addition, on that evening, this is not new to the agenda, we have a primary care advisory group meeting that starts at 5:30 p.m. And then also on our agenda for the month of May is on Monday, May 20th at 9 a.m. We have a CON hearing for the UVMMC Outpatient Surgery Center. And then lastly, on Wednesday, May 22nd, we have another panel discussion with a national perspective of value-based care. So please just check that out on our website so you can, especially for the public, you can keep informed on our very busy schedule for May. And then in terms of public comments, we currently have the VCures reporting manual, the updates to that out for public comment. We want to hear from folks by May 31st. And then the two ongoing public comment periods are one, the Act 167 hospital sustainability work. Please share any comments regarding that. And then any comments regarding the AHEAD model. Again, we share any of the comments we receive with the Agency of Human Services as they are leading the work on this next potential model. And with that, I'll turn it back to you, Mr. Chair.
Thank you. We have meeting minutes from just this Monday, May 6th. I'll move for approval of the minutes from May 6th.
I'll second.
All those in favor say aye.
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 Aye. And the minutes are approved. I'll turn it to Mike Barber, our General Counsel.
Hi, good afternoon. Back with you today to discuss the possibility of adopting formal guidance regarding consideration of affordability in the board's rate review process. And just to refresh everyone's recollection, the Green Mountain Care Board staff worked closely with folks from Baylett Health and the Center on Health Insurance Reforms to develop a draft guidance document on this topic. We shared that draft with Blue Cross Blue Shield of Vermont, MVP, the Healthcare Advocate, Department of Financial Regulation, and the Department of Vermont Health Access, and we sought their feedback. In general, the Office of the Healthcare Advocate was supportive of the direction and approach reflected in the initial draft, but raised several technical issues and questions to work through. The other commenters expressed opposition and concern in addition to raising technical issues, and trying to find a way to make what I felt was progress on this issue. I took a stab at alternative or revised guidance which I presented last week, and that alternative version drew some pretty strong objections from the Office of the Healthcare Advocate, as well as it sounded like opposition from Blue Cross. So I'm back here today to get some direction from you as to how you want to proceed. I don't have slides, but it seems to me that there are 3 potential options, although there could be more that I'm not seeing. So first, you could vote on the initial guidance. Second, you could vote on the alternative or revised guidance. And third, you could direct me or somebody to work through the issues with the initial draft guidance, kind of take those up after the QHP rate review process is over and come back to you at a later date. Regarding that third option, I believe Eric said this last week, that the issues they raised with the initial draft are not insurmountable. My sense is that is accurate, that we may not be able to address all the issues they raised, but I suspect we can address the ones that need to be addressed to do a reasonably accurate comparison of premiums and deductibles to the ACA and HHIS standards that we had identified. So that's all I've got for you, but I'm happy to hear your thoughts, and I'm happy to try and answer any questions you might have.
Any board member thoughts on Mike's options?
Sorry, could you
Sure.
clarify that last point? Sorry.
Go ahead, Dave.
Jess, just the last point you said, you do think it's possible to come up with a reasonable, is my audio bad still? All right. You do think it's possible to come up with a reasonable analysis of premium and deductions? Is that what you said? Sorry.
Deductibles, yeah.
Deductibles, thanks. Did you think that was possible to come up with a reasonable analysis of both of them with this year's guidance?
Yes. I think, we're largely, yes, I do. I'll leave it at that.
And you previously described the 2 different types of deductibles, and one was more complicated than the other, but do you think that there's a reasonable methodology to deal with both types of deductibles?
So I'm not an expert on this. My understanding is there's like 4 types of deductibles. So there's an integrated deductible, which is combining the medical and pharmacy deductibles, and then there's non-integrated or separate deductibles. So you have a medical deductible and a pharmacy deductible. The healthcare advocate, I think, suggested, combining those 2 separate deductibles and comparing that to the 5% threshold. That seems to make some sense. We can work through any objections to that. The trickier issue is the stacked deductibles. I assume that there is an approach we can take, whether it's just looking at the family deductible or something else. I assume we can. I don't see that. I imagine we can get through that. Yes.
Okay. Thanks. Sorry, Jess.
Oh, no, I was just going to say that I really appreciated the effort to address affordability. I know you put some work into this, Mike, and I appreciated all the commentary and the dialogue last week. I thought it was really enlightening, and I would support option 3. I think there's more work to be done on this, but I like the direction it's going, and with more input, I think could be really helpful to the board in the future. So I was just going to say, appreciate everybody's efforts, the continued dialogue, and I would support option 3.
Thanks. Mike, I also wanted to, well, I wasn't here last week, so I did watch the recording of the meeting, and I thought that it was a very helpful discussion. And I think that it's, I wanted to thank you and staff for all the work you did to bring this issue to the fore. I think it's a crucial thing for us as a board. It's in our statute that we should be assessing affordability. We've had no assessment, no formal assessment of it, no measure of it in the past. So I think it's a very important step. Other states are doing it. In your review of the literature, you brought forward some of their methods. There were comments last week about some controversy about whether to assess affordability or not, for fear of the board assessing it and reporting something as affordable, while families and Vermonters may still feel that it's unaffordable. At first, I listened to that and I reflected on it quite a bit. I ended up not agreeing with that. I still think we need to push forward with a measure and those labels, because we're charged with assessing affordability. And if we're not assessing it, but we're still passing rate increases, that alone suggests that we are finding them affordable. So we need a measure. It would be just one measure that we're looking at of all the other things that we're trying to consider. So all of this is to say, I think this is a very important topic. I think the concerns raised from public comments were excellent. I can continually learn from our public commenters. And I think if we give this some more time, we could move from reviewing literature to actually meeting with subject matter experts who have implemented measures. So instead of just learning about their conceptual thinking and how they outline what it could do, let's talk to some people who have actually implemented measures in the next year.
I'm comfortable with option 3. So I'm happy to hear the results of the further work when they're available.
I think we should take advantage of option 3 as well. So thank you for suggesting it, Mike, and to the hospitals and insurance companies and HCA that are willing to help us and work with us on that. Mike, I don't think we need to vote on anything such as that, so I will turn to public comment via the raise the hand function. Okay, great. All right, thank you very much, Mike. Oh, I'm sorry, Mike Fisher.
Yeah, I just want to pop on and echo what others have said. I really do appreciate the work and appreciate the great discussion last week, and look forward to working on this more with you.
Thank you, Mike. Okay, if there's no other comment, we can turn to Michelle Sawyer for the ACO budget. Oh, sorry, Abe Berman's hand is up. Mr. Berman?
Chair Foster, I don't want to interrupt Michelle's start here, but I just wonder if I could just give a quick opening statement about the budget.
Sure.
Thank you. I appreciate that. I just want to say we're committed to providing the board with the information necessary to fulfill the regulatory obligations that you have in a transparent fashion. It's a challenging process, I know, with the competing priorities you have, but we submitted a budget in 2023 that we felt represented our plan for 24. And, we think of that as the target we plan on hitting. It's meant to be the guide that we use throughout the year to determine whether we're staying on track with our financial targets and help us identify where we need to take action to get back on track in the event of unexpected events. A lot of things can happen between the time we create that budget, when it gets approved, and the actual start of the performance period, which we're in May of now, including just ordinary variation, revised estimates, staff turnover, etc. That said, the revised budget that we sent in remains an appropriate reflection of our plan for 24. And our intention over the past few weeks has been to answer any additional questions that the staff communicated to us and to provide information as requested. That said, there are always practical constraints on what we can provide, and like the board, we struggle with limited resources and bandwidth. We also have to comply with the contractual requirements in our payer and provider contracts. Just close by saying the prevailing model and the standard for most organizations to set a budget annually and then evaluate that regularly to see how the organization is performing throughout the year. Because no matter how comprehensive and complete budgeting is, things just don't go according to plan all the time. Regularly analyzing the variance between the budget and the actual performance is something that we've historically reported the board through our quarterly financial statements, and that we have every intention of continuing to do so throughout the year. And I truly feel like that's the best way to reflect changes in what actually happens versus what we planned on happening. So I just wanted to preface everything with that to say that, we're really committed to looking at that budget regularly and seeing how it plays out throughout the performance period.
Great, thank you. Ms. Sawyer?
Okay, thank you. So we're here today to look at OneCare's FY24 revised budget. I'm joined by our staff attorney, Mark Hengsler, and Matthew Sutter, our Deputy Director of Health Systems Finance. Here's a quick timeline. The light blue squares up top are for the initial budget process that started last fall. We now found us in the revised budget process. They submitted their revised budget to us on April 2nd. OneCare came in for their hearing on the 17th, and we are here today for our staff presentation. So the revised budget process was started a few years ago when OneCare started submitting their budgets to the Green Mountain Care Board. And due to timing, the initial budget submission was, apologies, the initial budget submission in the fall was based on attribution estimates and unfinalized payer contracts, making it necessary for the ACO to resubmit their budget when these particular items were finalized. The revised budget also gives the board an update on compliance with any pertinent budget order conditions that may have been issued into response to their initial budget. The staff have used the revised budget amounts to complete analyses of how OneCare budgets year over year, helps to inform budget targets that might appear in guidance, and it helps the staff to determine compliance with budget targets. So this language on this slide and the next few slides is pulled directly from budget order condition number 9 in the FY24 budget order. OneCare must submit a revised budget that includes all of the following items: A, final payer contracts; B, attribution by payer; C, a revised budget using a template provided by GMCB staff; and D, final description of OneCare's population health initiatives, including final care coordination. C has a red X next to it because of a lack of a submission regarding how they budget their administrative budget by function or program, which was part of the workbook, as well as a lack of an update in our adaptive software updating their budget for attribution. And there will be more on both of these subjects later. So E, hospital dues for 2024 by hospital; F, hospital risk for 2024 by hospital and payer; G, documentation of increasing the OneCare held risk and the amount ordered by the GMCB and any changes to the overall risk model for 2024; and H, source of funds for its 2024 population health management programs. Regarding G, while the submission in the workbook does suggest that OneCare is in compliance with this budget order condition, the staff are awaiting the submission of OneCare's updated settlement policy to reflect that OneCare's internal operations have been aligned to comply with this risk arrangement. The policy was updated by their board of managers about 3 weeks ago, and as of yesterday, it's our understanding that that policy is still routing for signatures. I, revised benchmarking report pursuant to condition 1. J, a report on the board's to the board on OneCare's progress relative to its targets for commercial payer FPP levels. K, statement of how these funds reduced from operating expenses were reallocated to population health and primary care programs. And finally, any other information the GMCB deems relevant to ensuring compliance with this order. This one is marked in yellow because it was a bit of a mixed result. There was a narrative portion of the revised budget submission that was completed in full. However, there were some items linked to other budget order conditions that weren't submitted, which will be discussed later. I'll also note that at the end of the slide deck, there is a chart that outlines the current status of each of OneCare's FY24 budget order conditions for reference. So before we get into the details about some of the issues staff have observed with the submission, Mark is going to walk us through some of the subsections of Rule 5 to orient us as to how the board monitors an ACO's performance under an established budget and how the board may respond if an ACO is not meeting the requirements of a budget order.
Hey, thanks, Michelle. So just a reminder, we are here pursuant to budget order conditions for the FY24 budget order. Condition 9 required OneCare to submit materials for, regarding revised budget. Condition 10 required it to present, which is what happened previously. The board's powers to really respond to those flow through Rule 5 at 5.407, which states that the board may review an ACO's performance under an established budget at any time. So this is just the time that we chose. Under the rules, such review need not be limited to financial performance. The board may cover any matter approved as part of the budget, meaning may cover material under budget order conditions. As the board has seen and done previously, there can be a determination, which is really a financial or budgetary determination, that the ACO's performance has varied substantially from its budget. We've seen that in the past. It can initiate a process for adjusting or revising the budget, which again is really a determination that there's a financial variance. But in addition to that, or as an alternative, the board may take any actions under Rule 5.407 to compel compliance with an established budget or compel compliance with budget order conditions. Next slide, please. So with that in mind, what any and all powers the board has, what are those powers? I'm just going to quickly go over those so we're all on the same page about what the board can do. First, Rule 5.504. If the board finds that an ACO is failing to meet requirements of an order or of conditions of an order, the board may, at its discretion, take what's called remedial action in the rule. There's no enumerated list of what all of the remedial actions could be. One example that's given in the rule is the requirement to have the ACO present a corrective action plan. The idea of a remedial action is that if there's a variance between what was required and what happened, the board might choose to take some action to try to get the ACO to remedy that issue and get back on track. This process has there's some process behind this. So before requiring remedial action, the board must provide the ACO a written explanation of any deficiencies that it's identified. The ACO gets 30 days to respond, and then the board posts that response to its website, accepts public comment, and then can choose at its discretion to hold a public hearing to discuss further. Either way, at that point, the board has the power to decide whether to take remedial action and the scope that it would take. Next slide, please. So while that's one mechanism that the board has to deal with a variance between what was submitted and what was required. The other one is not in rule, but in statute. So 18 VSA section 9381C provides that if an appeal or other petition for judicial review of a final order is not filed, the chair of the board may file a certified copy of the final order with the clerk of a court of competent jurisdiction. The order has the same effect as a judgment of the court and can be recorded, enforced, or satisfied in the same manner as a judgment of the court. A simple way of boiling this down might be just stating that this is a different mechanism the board has to kind of get at the same idea, which is that it can use a process to enforce a budget order or budget order conditions to ensure compliance. I think that's it for me, so I'll turn it back to you, Michelle.
Thank you. I think I'm handing it over to Matt at this point.
Thanks, Michelle. We'll just very quickly just go look at a condensed income statement. Here you can see the board ordered shift from operating expenses to population health management of $957,000. Apart from this change, however, the revised budget includes no other changes. As Mr. Berman mentioned, this is inconsistent with prior years. Next slide, please. In the past, OneCare has testified that the business model itself scales with attribution, total cost of care, the risk, spending. Obviously, there's fixed costs, but in the past, we've understood that that attribution does affect multiple areas of their budget. They've submitted a letter this year saying that they're asserting that the updated attribution figures are not material to the budget and do not affect the overall budget or programs. However, there's no way for staff to judge this. Materiality without knowing the attribution changes affect programs. So back to you, Michelle.
Thanks. So as we've discussed, the attribution affects the budget of an ACO, but it also impacts how much risk is distributed throughout the network. So I want to take a minute to go through that as we just received this information fairly recently. So here is how the amount of risk changed for the network between the initial and revised budget. The overall risk levels, which is inclusive of OneCare as an entity, the downside risk increased from 42.1 million to 44.4 million. And similarly, the upside risk increased from 32.2 million to 34.6 million. And the OneCare held risk changed more significantly. The downside risk went from 1.84 million to the 7.93 million, and upside risk from 961,000 to 7.07 million. The OneCare held risk is mainly a function of the budget order condition. Ordering OneCare to hold additional risk this year. So the key takeaway is that the revised budget was not updated for attribution. As Matt mentioned, in a memo from OneCare on Monday, they said that the updated attribution figures are not material. And while this certainly could be true, it is also true that they were required to submit a budget based on the final attribution numbers. And before Monday gave no explanation as to why they didn't comply with this budget order or ask for it to be waived. So the next topic is the administrative budget by function. The objective in collecting this information is to help the board and the ACO gain insight into what it costs them to run the ACO at the program and function level. This look at the administrative budget was recommended to the board by multiple consultants. The reports are linked in this slide. The board and the staff have requested this information from the ACO multiple times in the past year. So the key takeaway is that the submission, as far as the budget by function is concerned, was not completed, and there has been no indication of the ACO's willingness to comply with this in the future. And while not being able to provide prospective estimates of administrative expenses in this way might be understandable if ACO staff have never been directed to track their time by project, the ACO has known for nearly a year that this was a request of the board to be able to look at their administrative budget through this lens, and they could have worked to be able to provide this information in the future. And like I said, they have not done so, nor signaled their willingness to do so in the future. So outside of the revised budget itself, I wanted to bring up the budget order condition number 7, the verification on oath. So this oath required, or rather this condition required, that OneCare verify that all primary care earned PHM funds are being used to support and enhance primary care services. You can see through the flow chart here that when hospital-owned primary care earn money through their PHM program, the ACO sends those earnings to hospitals. And really what's a black box for the board, and it sounds like for the ACO, is whether those dollars are actually flowing back down to support primary care, as is the intent. And according to a memo from February, the OneCare Board of Managers does not feel that directing hospitals to expend funds in this manner is necessary or advisable. So the key takeaway here is that the submission was not completed, and there has been no indication of planning to comply in the future. So these are just a summary of the three kind of issues that the staff just wanted to alert the board to: the fact that the revised budget was not updated for attribution, the budget by function workbook was not completed, and the verification on oath was not signed, and there's been no indication of being willing to modify practices so they might be able to sign in the future. And then just briefly, here are some examples of some challenges with compliance we've had with the ACO over the last year or so. So in the FY23 budget order, Chair Foster wrote OneCare a letter in February of 2023 informing the ACO that they were out of compliance from their approved budget due to a lack of support for primary care. And this was really due to the loss of the Blue Cross Blue Shield payer program for that year. Later on in the year, there were some challenges around getting information around executive compensation and how those were benchmarked against national standards. Because OneCare was not willing to give us that information, the board issued a subpoena. The subpoena was argued in court, and unfortunately, we have received that information at this point. And lastly, the amended budget order. This is under appeal currently, but the board had ordered a cut to executive compensation as a whole to the 50th percentile of nationally benchmarked compensation. And the board had ordered OneCare to seek their hospital network to attest to how they are using primary care earned funds. I'm going to pass it back over to Mark to walk us through some of the options available to the board today.
So a few options here. Starting point, I've written take no action. Really, you could think about this in a few ways, though. So there's the option to take no action and find that these issues are not really worth taking effort to correct, or that there aren't, there aren't concerns on the board's part with these items. The other way of thinking about this is that we are approaching budget guidance for FY25, and we'll have a budget process sooner than we can imagine, for FY25. So one option would be to simply say, well, any issues that the board has here, it could choose to try to deal with future budget order conditions going forward. The same, just on that item, I suppose, is true of the fact that under this budget order, the board does have the power to, after notice and opportunity to be heard, make future orders or further orders that are necessary to carry out the purposes of the FY24 budget order. Timing wise, I'm not really sure, if one is better than the other, but that's an option available to the board. Basically say defer action for now is the way to think of item 1. Item 2, the board could determine that OneCare is failing to meet requirements of this budget order, which again is Rule 5.504. If the board made a finding that OneCare is failing to meet the requirements of the budget order, that would initiate a remedial action process where the board would write to OneCare with an overview of deficiencies, and OneCare would have the opportunity to respond before any remedial action plan was implemented. That could lead to a corrective action plan. It could lead to other remedial measures like a monitoring plan or an auditing plan or examples that are in the rule. Again, the idea for this item, for this part of the rule, is that remedial action is action that is designed to remedy regulated entities' failure to meet requirements of an order. The third option is that the board could file this and/or future budget orders with the court, as described at 18 VSA 9381C, and that would give the board powers of enforcement, as I described before. Staff do have some like template motion language prepared should the board want it. That's just in the appendix section of the slides. It's not something that we'll present to the board now. But with that, I believe I can turn it back to you, Chair Foster, for further discussion.
Thank you all. That was a helpful walkthrough. Mr. Boris, do you have a public comment?
Yes, please. Thanks for the opportunity to speak. Hi, everyone. Tom Boris, CFO for OneCare Vermont. Just a couple comments here based on the presentation I'd like to address. First, starting on slide 4, I disagree relative to the characterization of item C, which is to submit the revised budget. We submitted all the templates requested of us with our 2024 budget data.
Sorry, can I interrupt for 1 second? Can we just go to? I want to follow along.
Sure thing. Sure thing.
Maybe just a little bit slower so I can make sure I catch it.
Sure. Just disagree with this characterization, the red X there. We submitted all the templates provided to us with our 2024 budget information. The one tab that we've discussed previously that we're unable to populate was called budget by function and program. And we communicated before this process began. We just don't have that data and do not have a reliable methodology to slice our operations into the 19 categories requested. This is a timing challenge for me in the sense that this is a 2024 budget that will be based on some sort of historical basis that we just don't have. Moving forward, I'm open to discussing some segmentation. I think the 19 categories are far too granular for us to be able to do this. But for our 2024 budget process, it just represents data we do not have and cannot reliably submit. And remember, we submit all these documents under oath, and I just wouldn't be able to feel a level of confidence that it accurately represents an appropriate segmentation of our work. So we made every effort to comply and submit this the revised documents, but that is the one exception that we discussed previously. Next, on slide 5, please. Just to note, we will absolutely get you that policy and have every intent of complying. I think the numbers that you saw about the change in the risk demonstrate our willingness to comply with that order. So just a timing issue there, but wanted to say it publicly here. We have every intent to comply with that budget order and have OneCare hold 1% of the downside risk from the Medicare program. Next, I'd like to speak about slide 12, please. Jump to that one. Thank you. I really appreciate this slide, actually, and it shows why we didn't need to seek a more in-depth and thorough budget approval from the OneCare board this year. So as the OneCare business model is designed to scale with attribution, as the quote articulates, there are nuances, however, related to which programs drove that attribution variance. So this year, we had a 4% variation between the original budget that we prepared and the attribution numbers that came in, which is quite small in my opinion, and they came from Medicaid and commercial programs. Both of these programs commit and contribute PMPMs to OneCare that we then use to fund the payments that go to providers. And it works largely in balance. A little bit higher revenue coming in, a little bit higher expense going out. Because of this dynamic, we evaluated the materiality of the change and didn't feel it was necessary to go back to the OneCare board and ask for an increase in participation fees. So because the materiality was low, we didn't need to do a full budget recast with our board and change the amount the hospitals contribute to our efforts. I also thought I'd add, there's the box in the bottom right, which says there's no way for the board to judge materiality without knowing how attributions changes affect programs. This is something that can be seen in our ordinary financial reporting each quarter. Through that, we show here's the budget for something like PHM expenses, and then each quarter when we submit our actual expenditures, that difference can be evaluated and will help understand the difference between what we budgeted last summer and what we're experiencing in our actual operations throughout the course of the year. I'd also like to add some historical context here. This is the most 23 to 24 was the most consistent change or plan that we've ever had. Pre-pandemic, we were growing aggressively in the pursuit of scale years. And then through the pandemic period, we had a number of changes to programs and operations, just reflecting those uncertain times. We changed risk corridors, we scaled back operations, cut initiatives that we had planned. And then in 23, as you know, we lost Blue Cross Blue Shield as a contracted payer, significant change. 23 to 24 was the most consistent transitional fiscal year change that we've ever had. And the changes were very immaterial, in my opinion. And that is also why we did not go back to the OneCare board seeking a change to participation fees or any program dynamics or overall structure. So just thought that context was helpful to really say this is a consistent model, consistent operations from one year to the next. Thank you.
Mr. Perry, Aaron Perry.
Hi, Aaron Perry, legal counsel for OneCare Vermont. I have got 2 points I'd like to raise. The first is slide 14 related to the attestation. As the board knows, we do currently have on appeal undecided yet the issue of the attestation that the board ordered that we receive from hospitals with regard to an attestation that was in this year's budget order to be signed by CEO or leadership of OneCare Vermont. We would assert that the PHM payments that we make to hospitals are compliant with the APM, our contracts, and all regulatory requirements. And OneCare, in fact, does not have regulatory authority over hospitals or the ability to require hospitals to distribute or expend funds in a particular manner. So we wanted that on record. The next, and I don't know what slide it is, but it's the slide around historical noncompliance. I believe the two issues raised on there are the the support for primary care budget order, which is on appeal, and the executive compensation cut, which is also on appeal. Characterizing these as non-compliant, I think, is a gross mischaracterization. These were issues that we had a legitimate legal concern and controversy around, and we availed ourselves of due process, which is contemplated in Rule 5, that we could appeal budget orders to the Vermont Supreme Court, which we have done. So characterizing these as non-compliance is, we believe, a mischaracterization. Thank you.
Thank you. While we're on this slide, I think there's also, we're missing one. We actually had a board hearing, I think, on that fiscal year 23 support for primary care after Blue Cross. I think we had our letter, and then we had a board hearing, and then we had a board order mandating the payments be made. In terms of whether or not these are non-compliant with regard to the one subject to ongoing Supreme Court review, I would think that actually is non-compliant. If I think about like a trial court level decision, if you don't comply, you don't comply, but it's subject to appeal. It's not a non-compliant. It has a force of law. So if you comply with it or not, it's non-compliant. It's just subject to appeal. But I think the point about the appeal is important and is accurate. I'll open up to board comments and questions, which we usually do before public comment. But if any board members have thoughts, please go ahead.
I have some questions for our legal counsel, which I think we'd need to do an executive session around the options. So I think it probably makes sense for me to hold that until people have more discussion. But I did have just a couple of things that I wanted to say substantively. So when I looked at the revised budget group workbook submission, which has the updated attribution. The FPP targets table, which is the second tab, includes both the expected total cost of care as well as the new attribution, which I found helpful. And I'll just say for me personally, did help me assess the materiality of the change of 8,693 people in attribution across all programs, from 201,278 to 209,971. I don't actually find that a material change, and so it doesn't bother me to not get everything updated based on such a small attribution change. I think that originally it was really necessary to get that because there were such wide swings and changes year over year. And quite frankly, the board staff had indications from Medicare of their attribution estimates, and they were way different than the ACO's budget submission. So it made sense to me to do that process annually, so that, because it felt to me like the information we were getting in the budget was not necessarily reliable, and I don't mean that in a judgmental way, it's just it was difficult to project. And so it was important for us to get the accurate information. The original budget submission numbers look pretty close to me. So I don't personally feel like I need the complete resubmission based on an update of 8,700 people. So I just wanted to put that out there, is that I think we do have some information on the materiality of the budget in the submission. I think that question I should ask is really a legal question. In terms of the budget by purpose, I think that what I think that I understand the difficulty in potentially producing that retrospectively. I do think it could be helpful information moving forward as we think about transitioning in 2026. Potentially, I would assume, to a Medicare shared savings program. I don't know how the ACO programs might change as a result of that change in Medicare participation, or what the other payer programs might be. But I think having an understanding of the connection between functional areas and costs is helpful in thinking through that transition. I haven't looked at the categories, so I don't want to opine on the number of categories because I don't have an opinion on that yet, but I would be comfortable clarifying that as an expectation for 2025 in whatever way makes sense. And I guess I'll on the third issue, I can see, like, this is information that we've been asking for a while. I can see both sides of what, certainly why we're asking for it and why it's difficult to do in an attestation. So I'd like to see if we could explore another approach to accomplish that, understanding that it's on appeal. So I don't know if that's an appropriate action at this time necessarily, but I'm certainly interested in exploring how to get the information and clarity moving forward. So I thought I'd just throw my thoughts out there. And then when you think it's appropriate, Chair Foster, let me know and I'll move for executive session for legal advice.
Sure. I'll go ahead. I don't think I would support filing the order with the court at this time. They do have a force of law. It was not appealed when we made the budget order, and the budget order was made for good reasons. So it's a binding budget order. Nonetheless, I think that would be a little bit unnecessary in this context. I don't support taking no action. This isn't a first time we've had an issue with compliance with budget orders. They're not voluntary. Regulated entities don't have the options of picking and choosing which ones they like, or making materiality determinations. Our staff determined it was material. Our staff has reasons why they need it. And so I support the second option, which was to make a finding of noncompliance. It could have been discussed earlier. It could have been raised earlier to have an issue with these additional requirements. I think the budget by function one is really important, and I'll say why, which is I think not having that infringes on the board's ability to do its job. If we were to make a reduction, I think there would be a concern from the ACO as to why you made a reduction there, or why that amount. So I think having the budget by function allows the ACO to analyze what's working and what's not, and where the money should best be spent. And so I think that really infringes on our ability to do our job. And as to the materiality, it does allow us to do the year-over-year analysis, and it should have been discussed with the staff, and you could have gotten agreement that way. It's not to pick and choose which ones from the regulated entity's perspective. So that said, I also would just say that the budget by function and the primary care, these actually help the ACO. These help the ACO decide where to invest its money and resources to have the best achievement. And then the primary care one in particular, that's something we've all been trying to address for years. And it's a crux of the program and a crux of the ACO's intent. And we know that the ACO's performance on primary care quality measures is not where we want it. So understanding whether or not the money is going to its intent just seems really fundamentally important and should be in alignment with the ACO's objectives. I know maybe the hospitals don't want to give it, but maybe that's a conversation we can have. But I think it's important to do the job well. So in any event, I would support the second option for those reasons. We're a little out of order here with an opening statement and public comment kind of in the middle. So we'll just do the board part and then we'll go to public comment.
I appreciate hearing the other board members' perspectives, and I actually would appreciate hearing the legal advice questions in executive session.
Michelle, a question for you. I think you've answered this, but I want to make sure that I heard correctly. Do you feel that the staff needs the data, the budget data that's been requested, but not submitted to complete your work, our work as a regulator?
We typically use the revised budget numbers to compare year over year. And to not have that just for 1 year seems very inconsistent. So just having a consistent pattern of we receive an initial budget and a revised budget based on updated attribution numbers, that consistency, I believe, is important for staff to continue to analyze how OneCare budgets.
Okay, and the quarterly reporting that is submitted does not substitute for the revised budget in that context?
Not in this context, no.
Okay. And maybe this would happen in an executive session. So, but I would value a legal opinion on whether our legal counsel would agree.
Jess, I wouldn't. Yeah. You shouldn't ask legal questions publicly.
Okay, then I won't.
The question itself is privileged.
Okay, thank you. Then I have no other questions.
Sorry.
No, that's great. Thank you. Appreciate it.
Yeah. I'm also not okay with not taking action. I need to learn more about the similarities and differences between the other two options presented to us. From my perspective, as a board, we've ordered 3 things that have not been submitted in the way that we requested. And in some response, we've been informed that it's just not the way that the regulated entity chooses to do things. And to my reading, as not a lawyer, that is non-compliance. that if there's an order saying why you didn't do it as ordered is not compliance. So I'm not okay doing nothing. I'd like to learn more about our remaining options. But I believe something must be done.
I think, Robin, if you want to make a motion for executive session to get legal counsel, that would be fine.
I move that the board move into executive session in order to ask legal questions and get legal advice relating to this matter.
Second.
I
would-
think that, oh, Mike, go ahead.
This is one of the bases that requires a finding that premature general public knowledge would clearly place the public body at a substantial disadvantage.
Thank you, Mike. So let me amend my motion and turn it into two motions. So I move that the board finds that premature public knowledge of legal advice to the board relating to the ACO budget and potential non-compliance. If I said that in the right order, that the board find that public. Let me start over. I move that the board find that premature public knowledge of legal advice relating to the ACO budget order in front of the board would prejudice the board.
A second. All in favor, say aye.
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 And my apologies for
Aye.
not having this in front of me, so it's not rolling off the tongue. So my second motion will be to move that the board go into executive session to receive legal advice relating to this matter.
A second. All in favor, say aye.
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 Aye. The motion carries. I think we can leave this meeting and go to the other one, and then we'll come back. Thank you.
Hi, can I speak to Emma Schuman, please?
Dave Merman back? All right, we can resume our hearing. I like this different public comment. If you guys have public comment, we can do it now. The board, I think, might have a motion. Do you want to wait or do you want to speak now? We have Mr. Davis and Mr. Boris.
I wouldn't mind the opportunity to speak now, but I believe Ham was first.
Sure. Go ahead, Ham.
Thank you, Mr. Chairman. Can you hear me?
Yes, sir.
I never know when I'm unmuted or not. Anyway, I'm just curious. I wonder if you could do it yourself, Mr. Chairman. I would be encouraged by that. Could you just describe what the situation with the courts? There's a suit in process now, okay? And I'm just, it's very difficult to get a grip on what that is. I'm not even dead sure what court it's in. I assume it's the Vermont Supreme Court. But in any event, could you just, I know you can't say anything about the merits, but I just wonder if you'd say, okay, what is actually the court deciding? And number two, follow-up question, if it's legal for you to say that, what is the what will that, to what extent will that the court decision drive the decisions that you're trying to reach now?
I can do my best to address the first part. The second one's a little tricky, but I'm happy to try and address the first. And I think Mr. Perry's counsel, and there's other lawyers on here. I'm not a lawyer on this matter, but in the summer of 23, the Care Board decided that the compensation for a set of executives at OneCare should be capped at the 50th percentile of the benchmarks that they use as a group. So that order went into effect, I think, in August or so, and then OneCare appealed, as I understand it, on the basis of notice and the authority, some of the procedural issues around that, and the board's authority. And there's a second issue that's under appeal, which related to the board required OneCare to have an attestation relating to how those primary care funds were being used at hospitals. And I think OneCare appealed that one as well. And it is before the Vermont Supreme Court. It has been argued, and so the matter is pending before the 5 justices. And then your second question, I don't think I could answer. It really probably depends on what the court's judgments are.
Thank you, sir. Thank you very much.
Of course. Mr. Boris?
Again, thank you. Just a couple of comments related to some of the previous board questions I thought I'd take a moment to address. One is relative to the question from board member Holmes. I just have a different opinion. I believe that receiving the actual expenditures and the quarterly reports that we submit regularly throughout the year will give the Green Mountain Care Board every ability to evaluate the financial results relative to the budget orders. I'm sorry, Michelle, to be contrary on that, but I just view it a little bit differently. So I wanted to voice that one. Another is, it was suggested that having the budget by function as presented in the budget guide or documents would help OneCare. And I have a different perspective on that as well. I understand the spirit that you're coming from, but every hour OneCare staff spend counting widgets and really going down these administrative rabbit holes comes at the expense of work that they could be doing under our contracts and to fulfill our purpose and mission. And we spend an inordinate amount of time on the regulatory work, and any ability to redirect some of that time, I know you have obligations to fulfill, redirect that time back to working with our provider network in spirit of the goals that we share, I think is a really good thing. And in my personal opinion, I don't believe that extremely granular time tracking is a good use of the time and resources that we have and the staff and what they really should be doing on a day-to-day basis. Last comment is about Budget Order 9. OneCare submitted a revised budget, period. I think what we are stuck on is judgments as to whether or not certain numbers warranted a change. And I've been budgeting for much of my professional career, creating operating budgets, year-end projections. Sometimes line items warrant a change and sometimes they don't. We exercised our judgment as management, had conversations with our board, and determined that the changes that we know about now through the passage of time didn't warrant changes to certain line items in our revised budget. That doesn't mean we did not submit it. And had we not had the budget orders requiring the shift in admin expense to population health management expenses, it's entirely plausible the revised budget would have been exactly the same as the budget submitted initially last fall. So I want to make that distinction between submission of a revised budget and an expectation of which numbers change. That's a judgment call or a judgment decision. And our board voted to endorse the budget that we submitted earlier this year. Thank you.
Thank you. Any other public comment? Right. I have a couple motions, unless there's any other board comment at this time. Great. So first, I move that the board consider a revision to the fiscal year 24 budget, requiring OneCare to prospectively include in its contracts with hospital providers a method for tracking population health payments to ensure those payments strengthen the provision of primary care.
A second.
All those in favor, say aye.
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 Aye. Motion carries. And just for people following along, this is the motion that I made was to consider a revision to the fiscal year 24 budget. It's not actually a revision to the budget. It's for the board to go forward with considering how to revise the budget to add an order relating to that provision. Second, I move that the board consider a revision to the fiscal year 24 budget order requiring OneCare to prospectively implement a method of reporting its administrative and operational expenses by function, such that OneCare and the board can sufficiently identify the administrative and operational expenses of various OneCare programs. Such a revision will require OneCare to describe and implement a process for tracking the benefit of each program for Vermonters. All those in favor say aye.
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 Aye. Motion carries. And the third motion I have relates to condition 10B from the fiscal year 24 budget order. And I move that the board hereby determine that OneCare has failed to meet condition 10B of the fiscal year 24 budget order, requiring a revised budget based on final attribution. The board shall provide OneCare with a written explanation of the deficiencies it has identified along with supporting data. OneCare shall respond to the board's explanation and any proposal for remedial action in the manner and timeframe required pursuant to GMCB Rule 5, Section 5.504. All those in favor say aye.
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 I'm going to abstain.
And the motion carries. I would ask for public comment as well, if there's any on the motions. Mr. Berman?
Hey, Berman, CEO, OneCare Vermont. Can you explain what 10B specifically is, Chair Foster?
That was the revised budget based on the revised attribution.
Okay, so I'll try to be brief. The purpose of the budgetary approval is really to determine if an organization, and this is my perspective, so I'm not telling you what to do, to determine if an organization has appropriately allocated its resources to accomplish its mission. By that, I mean that we use the money appropriately to get things done that we said we were going to get done in accordance with the contracts and the agreements. The level of micro interference that the board is seeking to engage in is not productive, and it's unclear what is in that motion to the benefit of Vermonters, what that means. Which Vermonters are you talking about? I just find this whole process to be extraordinarily focused on a level of procedural value and not actual value to Vermonters. So I'd ask you to really think carefully about how you proceed here and say, does this really end up helping provide better care to Vermonters? And I just don't think that's the case. That's my opinion, and I'm voicing it as a member of the public.
Thank you for sharing your opinion. Is there any other public comment? Ms. Gutman?
My observation is that I understand you don't want more work, and work is expensive to do, and you want to focus on the purpose of the work. But what I hear in the discussions and questions and so forth has to do with the fact that OneCare has not been achieving the goals that it ever had before it. So I see it necessary to understand why. And you can't understand why without information and data that I guess the board is asking for. That's my observation. Thanks.
Thank you for your comment. Mr. Berman, I see your hands up again.
Just like to briefly respond. We have provided reams of information against objective criteria of our performance. The idea that we somehow have not done that or not provided some piece of information that is the linchpin to deciding whether we've been successful or not, which is completely arbitrary, Ms. Goodwin, is just wildly inaccurate. And the amount of time and bandwidth that it is consumed by this process does not generate better outcomes, period. That is all.
Thank you for your comment. Anyone else? Mr. Boris?
I'd like to ask the board to define final attribution for me, please.
Ms. Sawyer, I think that's probably more your domain of exactly what you need.
Sure. So we do have a tab in the workbook that asks for an updated starting attribution and a final or let me see what the term is exactly. Give me one moment, please.
And Ms. Sawyer, if you want, you can just look it up and then email them the definition, because
Okay.
we're running a little bit over time today, and we can just send it to them.
I can maybe help with a quick answer.
Sure.
I would define it as finalized contracts as of January 1. So contracts at the time of budget submission were not finalized, then they're finalized. So what is your starting attribution for January 1 based on finalized contracts?
Mr. Boris, do you have another comment?
I do, thanks. Well, I posit that attribution is not final until the conclusion of the performance year, and settlement occurs with the payers. There is a process that the payers go through that determines at the end of the year how many attributed lives on a member month basis we have. That process includes exclusions. You're familiar with the QEM process in Medicare, I'm sure. So final attribution will not be known until settlement occurs about a year from now, year plus from now. So it is an impossibility for us to say, here's final attribution and here's what our budget is based on that number today. My point is, attribution is a living, breathing thing. We get an initial number before the performance year begins. And throughout the course of the year, there's attrition. People pass away, become unattributed for a number of different reasons. So asking us to build a budget based on final attribution is an impossibility.
Sounds like probably more of a staff level discussion rather than a board discussion. But if there's ways you've done it in the past that you want to discuss with staff as how you did it previously, that seems to make sense to me, so it's consistent.
Sure. To say it briefly, it is and will be an estimate. It's an estimate in our budget, and it's going to be an estimate throughout the course of the year. So.
Any other public comment?
One final thought, Chair Foster, if you don't mind.
Sure.
There was an assertion made that we did not communicate in advance what we were going to submit and that we have not been forthcoming in answering questions. So when the suggestion is that it's a matter between us and staff to determine what final attribution means, it's challenging because my staff was in active communication with the staff of the board to answer any questions that they had. And we remain in active contact with them. But to have that characterized later that we did not answer questions or were not forthcoming or did not telegraph what we were going to present is challenging. So I think it's important that Mr. Boris brings up the definition of something like final attribution, because that word is powerful and is in your language of your motion. So we need to define that really carefully, because as Mr. Boris says, the way these contracts work, we don't actually get that final attribution until the end of the performance year. So it's really important that we get the details right in these matters.
How did you define it in the past?
I don't believe we have. We don't,
so in prior
we don't use
years,
the
what did
definition
you
final
use to
attribution.
submit?
We have attribution at each quarter as we update. Mr. Boris could comment on that more than I could.
Well, on that, I'll just say this process is the same, where we estimate and evaluate attribution in prior years. There are much more substantive changes to our business model from one fiscal year to the next. And, per discussions earlier, this was a very seamless and smooth year, so we didn't feel a change was warranted. I'd like to add one more comment, which is to say the budget isn't really what matters. I know it's the focus of the regulatory process, but we can go in these circles around the budget endlessly, and it won't change how much this costs, and it won't change the impact on the providers that we serve. What really matters are actual operations, how things unfold throughout the course of the year, and we're stuck in a swirl about a budget that really has no bearing on cost, quality, or healthcare outcomes, other than the essence of it, which is the plan that we endeavor to execute throughout the course of the year. And I strongly encourage this board to evaluate the budget through that lens. This is our plan of our board and our provider network. There have not been substantive changes to that plan between the initial submission last fall and the submission that we supplied earlier in this calendar year.
Anything else? Okay, is there any old business or new business for the board? And I will move to adjourn. All in favor, say aye.
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 Aye. Thank you, and we are adjourned.